The ABIM Foundation paired frontline physicians and leading experts to discuss building trust in healthcare. Christine Sinsky, a physician and AMA official, and Melinda Ashton, a physician and chief quality officer, focused on efforts to build trust by eliminating inefficiencies.
Well, hi, Melinda. I am so thrilled to meet you. I'm Chris Sinsky. I'm a general internist. I also work at the American Medical Association as Vice President of Joy in Medicine.
Chris, it's so nice to meet you. I've been looking forward to this. I'm Melinda Ashton. I'm the Chief Quality Officer at Hawaii Pacific Health and also a pediatrician.
Great, great. Well, I first learned about you in your New England Journal article and the work that you've been doing about getting rid of stupid stuff. And I wonder if you can tell me a little bit more about what you did and why.
Yeah, it's a funny story, really. I had seen over the years that there were the occasional documentation thing in the chart when I was reviewing a chart where I was pretty sure that whatever was being documented wasn't actually really accurate to what occurred. And then we bumped into a couple of more worrisome areas where we had clearly allowed to be created in our EHR documentation requirements that just were plain stupid. And so we talked to I'm a member of the executive team, we talked to the rest of the executive team and said, maybe we should do something about this. We've stumbled on these. I wonder what else is out there. And we decided that we would create this program at our place where we just invited anybody who was using the EHR in any way to tell us what was just plain stupid. None of that was intentional, of course. We sort of started off by saying stupid is in the eye of the beholder here. What we now are saying is stupid was well-intentioned when it was started. And we've been really pleased and surprised by the amount of interest and involvement from our staff and outside of our hospital as well. Health system, sorry.
Well, one of my favorite examples was a nurse had mentioned that she thought it was odd that she was having to document the status of the umbilical cord in a teenager.
Yes.
And perhaps you can tell me more about that.
Yeah, that was one of the very early nominations, as we call them, and we were just beside ourselves. I mean, it was hard to believe that we had this particular documentation requirement in our EHR for patients in the pediatric hospital that we have for at least 10 years. And this was the first time that we heard from a nurse that she really would hope that we would take away the need to document that the cord was absent in the patients that she cared for, which were adolescent and oncology patients, almost never newborns. All that was a simple failure to put in the age restriction that was intended when we built the EHR. And it was just mind-boggling that for year after year, patient after patient, a nurse who was actually a very strong advocate of her patients hadn't spoken up for her own behalf to say, please make this go away. Yeah. And as soon as she did, we made it go away.
But you had a process, right?
Right.
I've been through 2 different EHR implementations, actually 3 if you count our hospital implementation. And I and others filled out many forms for suggestions for enhancements or improvements or we didn't have that term, getting rid of stupid stuff. But after a while, you learned that that was a futile exercise. Yeah. And yet there's something different in what you did that made it not a futile exercise.
I think that is one of the things that we've heard that has made it a bit different than others. Now, we are well past implementation. We implemented our EHR back in the 2004 to 2010 time range, so it's been a long time. At that time, our IT staff got really good at building because they built 4 separate hospital implementations, each one a bit different. They got very good at that. So over the ensuing time, what happened was they were really good at responding to requests for improvement. And now what we found is some of those improvements actually have turned out to be, unintendedly bad. At the same time, the EHR, any EHR, is so complex that any implementation, I think, is likely to miss some of these little things. And so we found a few of those, not as many as perhaps we thought we might, but those are the fun ones. Those are the ones that you just sort of shake your head and say, how could that possibly be true? But those have been there, just some, but many of them have been things that, a group of folks thought was a really good idea to do something. And then, years later, you look at it and you think, oh, that did not work out as intended, that was kind of stupid. It results in a lot of rote work by nurses, by therapists, by staff, that just pulls into their time for talking to their patients, relating to one another, doing the work they really should be doing.
We're here at this conference around trust, and I'm thinking about my own experience when I and other physicians did raise examples of things that could be eliminated, could be changed, ways to make the usage faster, quicker, more efficient, and almost feeling as if there was a social cost to be paid for those who raised those objections. And yet, I'm understanding what you did as having been a source of building trust among the physicians and among the other clinicians. And I wonder, am I right on that?
Yeah, I think you are. I mean, I can't tell you how many nice emails I've had from people that rarely say nice things. Yes. And so I think that, and we've heard a little bit of a, hey, I said something and you changed it, kind of a building of trust, I guess, in that term. The difference, I think, is, first of all, we had executive sponsorship of this. This was something that our CEO on down really bought into. Our CEO, for example, found one of his own examples of something that was completely stupid, that had been going on for years and years, that he was willing to go out and talk about. And so that was helpful. We had a couple of really good examples to start us off. I think that was helpful. And then our partnership with the IT was critical. And we already had an infrastructure. We had work groups that were specialty specific or discipline specific that were ready and in place and doing this kind of work. And they were able to then take those practice requests and actually implement them. Evaluate them, first of all. We don't do things just because one person asked for it. We make sure that it's not going to be another stupid something that we build. Yes. But those work groups are really helpful in terms of doing the evaluation and then actually, making sure that the build happens and that it gets done in a timely way and so forth. And we stay in touch with the people that make the recommendation to us as well.
I would think there needs to be a fairly deep level of trust between IT and the physician leadership, because they're the ones who are probably going to feel the most judged, or the most threatened by this. We built it this way, just live with it, or something along those lines. So how did that happen that they were not overly defensive?
That's actually a really interesting set of thoughts, because when we were first known to be working on this, getting rid of stupid stuff, our CIO got a number of emails from friends and colleagues around the country all saying, "What are you thinking?" And he sort of chuckled, and his response, at least internally, he was sort of saying, "Well, I just say back to them, do you have that much stupid stuff that you're worried about?" But the real truth is that we've built the IT clinical relationship over years, and they are very much our partners. They really understand that their role is to help us provide really good clinical care. And I think that's a little different than perhaps in other organizations. Now, I should say that years and years and years ago, when I first started to try to interact with IT, I was told by the same CIO that he told every one of his people, first answer to any question is no.
Yes.
And then you think about it. We've changed that thinking.
I think you've really hit on something there. As I was thinking about your initiative, getting rid of stupid stuff and trust, I was thinking about how, as a physician, I, early on in my career, absolutely implicitly trusted my leaders to help me take good care of patients.
Right.
And then the EHR was instituted. And it made it really much harder for me to take care of patients in some regards. In other regards, it made it easier. But I felt like there was so much pressure, and that trust was broken because I no longer trusted that the leaders were actually there to help me take better care of patients. The message became, implement the EHR and don't complain, or and stay quiet.
Yeah.
And you may have started, it sounds like, with a little bit of that attitude, but that evolved, and I'm guessing that getting rid of stupid stuff helped others trust that had evolved.
I think so. I think being able to go out there and say that we are going to work on getting rid of stupid stuff, which by itself is a little bit in your face.
Yes.
That was helpful. And that message, and actually the article in the New England Journal, of course, gave it a bit more credibility as well. But I think all of that, plus the fact that we were able to make the changes that were being requested, we really sincerely wanted to know what we had created that wasn't helpful.
Yes.
And I think it is absolutely true that it's the leadership's role to set the environment. You know, the individual clinicians can't change that by themselves. It's only leadership that can, and leadership can't do it if they don't know what's needed. So we need that partnership there.
I'm curious about the name.
Yes.
I love the name. And I think if you just had a comment box and asked people to put in comments, you probably wouldn't have gotten as much engagement.
Right.
But I've also heard a little bit of pushback about stupid.
I agree.
And yet I think if you didn't have stupid, it wouldn't have worked. That stupid just resonates with us. We know that's what's taking up so much time.
It does. We actually had some serious conversation at the executive team level about whether we were going to call it stupid.
Yeah.
And at first it was, when I was presenting the examples that we'd uncovered, I basically threw up my hands and said, this is just plain stupid.
Yeah.
And then we talked about we would have a program for administrative simplification. And I think the system goal actually had that terminology in it. But then we looked at each other and we said, no, we need to go out there and tell people we really want to get rid of the stuff that's totally stupid.
In fact, I think by saying getting rid of stupid stuff, you actually engendered trust.
Yeah.
Because you were able to tell it like it was.
Right.
You weren't sugarcoating it. You weren't saying it's optimization.
Right.
We really weren't wrong at the beginning.
Right.
We're just optimizing. No, we're saying, there was a lot of stupid stuff here. Yeah. To me, that just resonated so clearly.
It was interesting. As I went out to present this as a new program to our managers, directors meetings across the system, we have 4 hospitals, 4 of those meetings plus 1 at the system level. Every time I put the title up and started to talk about it, there was just a ripple of kind of sheepish laughter that went through the room each time. And I had one of the people that reports to me tell me that if I hadn't been up there standing them, telling them that that's what we were truly thinking about doing, that somehow it wouldn't have, been as trusted, I guess.
I would say there's a leader who understands something about my life if I heard you speaking that.
Mm-hmm.
Well, I want to tell you, I had the chance to visit another organization, another academic medical center, or an academic medical center, and they had just called someone from your department and they were going to replay that initiative or copy that initiative. And they were really enthused about it. They had gotten, I believe, 450 suggestions in the first 3 weeks.
Wow. That's great.
Yes.
I just love the fact that other people have decided there's something here that they want to kind of replicate, or I'd love to see it just ripple. I think it's great.
Yes. And I want to thank you because you're helping us make that ripple.
Yeah.
You're helping us write a toolkit online at the American Medical Association on getting rid of stupid stuff so others can be inspired.
We're happy to talk to anybody and help anybody do this. I think it's so exciting that others want to do it.
I think we learn by example, and you've just given us a great example.
Yeah, that's good.
So I'm really pleased that you've made the trek all the way from Hawaii to come and share what you've learned with the larger the larger group here at the Forum.
And I'm really pleased that I was invited to come and do that. I'm absolutely excited to be part of this.
Great. Well, thanks. I think you started a movement.
Thank you.
Visit buildingtrust.org to learn more